Good afternoon, everybody. This is Susan Evans from Seeing is Believing. Welcome to the first Seeing is Believing Africa region webinar. I'm just going to start by thanking everybody for making the time to come today. I really appreciate how busy everybody is. So thanks for making the time for this, and especially thank you to our two speakers, Emmanuel Kumar and Mary Wepo. So let me pass over to Sally Crook for a brief introduction.
Hi everybody, good afternoon, and thanks so much for joining this very first SiB webinar. And also a very big thank you to Susan, who has done all the organising for this, looking into the best platforms to use and everything. So many thanks to Susan, but we really hope that this goes well and that we'll be able to deliver more on new topics going into the future, and that it provides a really good and exciting way of different Seeing is Believing staff members out there in the clinics and the hospitals and in the sort of head offices to sort of share learning and to come together with issues that I'm sure will be common to a lot of us. Also, thank you for our two presenters today for starting us off. You've been really great in agreeing to be the guinea pigs for these first ones, so thank you very much to Emmanuel and Mary. And I'm really excited to see how many people we can engage with in these webinars, and there's 24 of you logged on at the moment, so I hope everybody can hear and has a really enjoyable time engaging with the webinars today and in the future. So anyway, over to Susan, who maybe will be introducing our speakers, or if not, Mary, you can head on straight now. Thanks.
Okay, so actually, can we start with Emmanuel? So Emmanuel Kumar is the Operation Eyesight Universal Ghana Country Manager, and I'm just going to get his presentation up here. So okay, great. So Emmanuel, over to you.
Good, thank you, Susan. The presentation, as we are all aware, will focus on eye health system strengthening in Ghana by Operational Eyesight and SiB in Ghana. Next slide.
And sorry, could I just remind everyone? Could I just remind everyone? Could you just switch off your microphones and your webcam, because it will just make it a little bit clearer for everybody. Thank you. And that's just by clicking the microphone at the top right. Okay.
As we are all aware, eye health systems consist of all your organizations and people whose actions are primarily intended to promote, restore, and maintain eye health. Operation Eyesight Ghana and Seeing is Believing projects have implemented programs in action and for the past year to strengthen eye health systems in Ghana. Can we go to the next slide? We're going to go through the eye health system framework by WHO. Number one is service delivery, followed by eye health workforce, information and research, medical products and technology, financing, leadership and governance, and credit. WHO. All these ones are going to contribute to improved health, responsiveness, social and financial protection, and improved efficiency as the overall goal of the system building blocks. Next slide, Susan. If you take service delivery, we are saying that good health services are those which deliver effective services and efficient services. And in that respect, what we have done as Operational Side and Seeing is Believing is to raise demand through awareness creation. And in this case, we have embarked on extensive TV commercials and awareness creations throughout Ghana. We have also integrated primary eye care into primary healthcare systems in the country to help the service delivery system, and again supported outreach services across our partner districts. When it comes to eye health workforce, what we have done as a project is to train over 1,000 primary eye care workers across our 35 project sites. We have also built capacities of frontline ophthalmic personnel. In this case, we are talking of ophthalmic nurses and optometrists. And again, we have also advocated for a fair distribution of eye health workforce in not just the partner district, but also across the country. We are working in Ghana.
It might be also from his side in Ghana.
That's like some. In terms of information and research, we have had the opportunity to train regional health information officers regarding eye health indicators and how to impute them in the district health management information management systems that operate in Ghana. So what we have done is to make the regional information officers very much aware of the key indicators as far as eye health is concerned, and how to interpret them to make meaningful information to people. Again, we have also embarked on a national blindness and visual impairment study so that we can get real figures and data to support any advocacy that we're going to embark on. Presently, what we are doing is to use WHO estimates when it comes to eye health, and we believe that when the research report comes out, then we will have actual data to quote in support of any advocacy that we're going to embark on. In terms of medical products, we have also, as a project, supported our various partner hospitals with cost-effective surgical consumables that are available on a sustainable basis. Again, we have also provided limited infrastructure and equipment to all the partner hospitals we are dealing with, so that at least they can service the patients when they come for services. Next slide, please.
It must take them a while to see on the slide. I think it takes about 5 seconds.
In terms of financial and social protection, what as a project we have partner districts comes up with a revolving fund, because as a project we are giving equipment, we are giving consumables, we are training them, and the belief is that when patients come and they are treated, the monies that are paid by the National Health Insurance, because the system that is in Ghana, the hospitals will use them as a revolving fund to serve as a basis so that for the expansion of the eye units, to support outreach services, any assistance that the unit will desire for the hospital. Again, we support the conduct of surgeries where need is, in terms of people who do not have the National Health Insurance, but then we need eye health services. In terms of governance and leadership, we supported the National Eye Care Unit to draft Ghana Eye Health Policy for consideration. And we believe this is key to guide all the activities of eye health in the country. And again, we supported Eye Health NGO Forum to advocate for the development of eye health in Ghana. Next slide. While doing all these things, we have encountered some constraints in terms of financial assets. As I earlier on alluded to, Ghana have a health insurance system where after treating patients, the hospitals are reimbursed. But this takes quite a number of months before the hospital gets access to the fund. And it render services. Again, in terms of commitment from leadership and management, some of the facilities we are working with, because of change in leadership and at a point, the commitment that was started with going down, and you have to start all over again in terms of advocating for people in management position to be committed to the development of the program. And again, poor staff motivation coaches as a result of the fact that because the facilities are financially constrained, it becomes difficult for the eye unit to embark on outreach services, to procure additional equipment and medicines that will help the development of eye health services. Again, because there are districts that are being created anew, hospitals are not available there, and getting access to eye health is a challenge. We all know that eye health is a collective effort in terms of its development. But then there are instances where instead of the health service itself and the department within and working together, they are not really working to put up plans to help achieve the development of eye health services. Next slide. But notwithstanding that, even though they are constrained, as a project, we have tried to minimize the constraints in terms of using advocacy for the timely release of the insurance reimbursement to the hospitals, and also to advocate for comprehensive health care, including eye health, and then advocate for the inter-sectorial plans to counter any acts that are hindering the development of eye health. And again, in terms of outreach, because of the financial constraints, as a project, what we have done is to try and support the unit with travel and transport, snacks, lunch, and then fuel and medicines, and also to equip them with portable equipment to facilitate outreach services. So in brief, as a project in Ghana, this is what Seeing is Believing and Operation Eyesight has done to strengthen the eye health services in Ghana. Thank you.
Thank you, Emmanuel. That was great. That was really good insight into what you're doing in Ghana in terms of linking the project within the existing health system and how you're strengthening the eye health system within the project. So thank you so much for that. All right, then we'll go straight into Mary's presentation now. So Mary Wepo is the Africa Programs Manager for Brian Holden Vision Institute, and she's going to talk a bit about how within a range of some of their Brian Holden Vision Institute projects, they've been strengthening the eye health system.
Thank you, Susan. As introduction, as Susan said, I chose to talk just on two elements of the health systems, and that will be the health workforce and service delivery. And I'll do that by using examples from a range of projects that we have implemented, funded by Seeing is Believing. So on the first slide, you will see there are 5 projects that we have implemented over the years, which have all been funded by Seeing is Believing. The first one was in South Africa. It ended some years back. The second one was in Nigeria. It was also a 4-year program that has now come to an end. And giving sight to Gauteng. Gauteng is a province in South Africa. It is still a current project, still running. And number 4 is the East Africa Child Eye Health Project, which is still running. It's a 4-year project. It will be ending in December of this year. And it covers some parts of Kenya, Uganda, and Tanzania. And the 5th project, it has that asterisk because it is very new, so I don't think there will be any lessons to share from that project at this point. Thank you, Susan. Next slide. Yes, so I chose just to look at 2 elements of the health systems, and that is the health workforce. So I'll start with the health workforce, And as I said, I'm going to draw examples from the various projects that we have implemented in partnership with Seeing is Believing. Now, I've said that what we have been able to do is to improve the HR situation, both in numbers and skills. And why I say both in numbers and skills is, so I'll take one example. The first point says we have been able to support through the employment of optometrists. This is a specific example from the South African project, both the one that was in KwaZulu-Natal that is over, that is ended, and the one that is still running in Gauteng province. Now, what is very interesting is that South Africa has a lot of optometrists, but many of them, majority of them are in the private sector. And when we began the KwaZulu-Natal project, which was in 2007, in this specific project where the brand holding office is, rather specific province where the brand holding office is, we did not have any optometrists employed in the public sector. All optometric services were in the private sector. So as some of the outputs for this project, we did a lot of advocacy to bring optometric services or refractive error services into the public sector. And so to do that, we had to advocate for the Department of Health to create posts to employ optometrists within the public hospitals. That had never been done before. So by the time the project was ending, we had managed to convince the Department of Health to create posts for optometrists and employ them. But we began by employing them through the project, but over time the Department of Health was taking them over. And we have managed to take the same approach to other provinces in the country through the Seeing is Believing funding as well in Gauteng province. Use the same approach, start by employing optometrists through the project, but the Department of Health eventually has employed optometrists over time. So that has been a great contribution of our work together with Seeing is Believing, just to bring refractive error services into the public health system and to get optometrists employed within the public health system. And so with skills, training, primary eye care workers, and we have done this in all the projects that we have implemented in Nigeria, in Kenya, in Uganda, in Tanzania. That way details, basically these are the nurses being trained in primary eye care and child eye health as well where relevant, and also refresher courses. Some of these nurses, for instance the ophthalmic nurses that we have in South Africa, ophthalmic assistants in some countries, we offer them refresher courses so that they can bring their skill level up to date. At the same time also, even optometrists in South Africa and in Nigeria as well, we have offered them refresher courses just to refresh their skills training. With skills as well, we have provided low vision and pediatric optometry courses. So here again, we have done refresher courses mainly in South Africa and Nigeria, because there in those two countries we have quite a good number of optometrists and people in low vision who just need refresher training because they already have that skill. But in some countries in East Africa, we've had to take a whole new lot of people to be trained in this skill. And those have been ophthalmic clinical officers and optometrists from Tanzania, who have been trained in low vision and pediatric optometry. That's increasing that skill among the eye health workers because well, the skill was not there, but now it's been added to them. So while it has been good that we have been able to improve the skills and also bring the numbers of the eye health workers within the public sector, I have to say something briefly about creating an enabling environment. as I mentioned earlier, for instance, with optometrists in South Africa, the department would agree to employ them, but then there will be no equipment for them to work with. So we also took it upon ourselves as part of this project to create an enabling environment for the optometrists to work, and we provided clinics with some equipment to enable the optometrists to work. And the same with the people that we have trained, the OCOs and optometrists in East Africa. We've also provided them with some basic equipment that they can use to work when they go back to their workplace. So while I did not talk much about the infrastructure and environment where the personnel work, I just thought I should point this out because training the workforce without taking care of where they're going to work would not necessarily provide the desired outcome. So there was a bit of refurbishing or equipping the eye units. But for instance, in Nigeria, we had to build like 3 eye units, and one of them was a high-level eye unit providing cataract surgery and all that. So we did provide that level of support in improving eye care infrastructure. I can't tell you the numbers of eye units we have equipped and refurbished because there are so many. I would have to do all the additions from all the projects that we have implemented together with SiB. Thanks, Susan. Next slide. So as I said, the other element I chose to talk about is service delivery. But again, as we know, service delivery is so broad because with iHub, we're looking at delivering services to everybody who needs eye care services. But I thought I should talk just about children for this particular presentation, given the time that we have. So I chose to talk about how we have improved service delivery for children through the Seeing is Believing project. Now that picture there, those beautiful children, school children sitting there looking very nice and clean, are children in Uganda. What they're carrying in their hands are referral forms, and those are their teachers. Now these children have been screened by their teachers, and they have been brought to the health facility to be seen by a health worker. This is through the current Child Eye Health project that is going on in the 3 countries in East Africa. So this picture, I think, says quite a lot how we have improved services for children. So from screening in school until they reach the health facility, with the teachers, they're waiting to be seen by a health worker. Next slide, Susan. Yes, so just straight from that illustration of that picture, what we have focused on doing with the Child Eye Health project, whether it is in East Africa or Nigeria, where we had an element of school eye health program, and same in South Africa, is to establish a model for eye health delivery for children. So it is both young children, 0 to 5, and even the older children. So for establishing here, we're looking at in a situation where there's no system, no model of providing eye health services for children, we have worked at establishing that model. But where there is already some sort of system for providing eye health services to children, we have been working towards strengthening that model that is already in existence. So, for example, in South Africa, there is what is called the Integrated School Health Program. Now, this is a school health program under the Ministry of Health, the Ministry of Education, but delivered by the Ministry of Health. So we have a school health team that visits schools to provide basic health services to children. Now, what we do here is to support that program, to strengthen it. So what we have done is to train the school health teams in basic eye care, so that when they go to the school, they're also able to screen the children for eye conditions and refer them appropriately. So South Africa is one example where we are working at strengthening a model that is already in existence. And an example where we are working at establishing a model where there isn't one as such would be, I'll give the example of, let's say, the East Africa project. In as much as each country has some form of school health program in which they say in policy that eye health is part of it, the reality is that actually the eye health component is not really being given much attention. So we may say that we are working at strengthening that, but actual sense is we are trying to establish that eye health component within the system that we say is already in existence. So, and the same with Nigeria, for instance. So here what we have done to improve service delivery for children is to train teachers, school teachers, so that they can be the first, since they're the first point of contact with the children, to screen the children, identify basically, visual acuity and an eye that doesn't look normal, if I should put it that way, and refer the child to a health professional. By doing this, we're improving the service delivery for children because, one, the starting point for a child to receive services is to be screened and to be identified that the child has a problem. And so by training the teachers, that's the entry point into integrating this into the education system or the education sector, so that ministries of education do recognize the importance of eye health in education and advocate as well to find systems or to implement the policies that they have in providing eye health as part of their comprehensive health policy that they have. So we have made good progress in that aspect in East Africa and Nigeria. And just overall integrating eye health into general primary health care. Now that is the whole reason we are training general nurses in primary eye care and child eye health. We're training the maternal child health workers, those ones who see the babies in the clinics. And we have been emphasizing, particularly through the East Africa Child Eye Health Project, that every child who comes to the health city should have their eyes as well screened. And if there is a problem identified, then they should receive the appropriate treatment straight away. So this integration is to start right away from the time a child is born, when they start going to the clinics where they receive the immunizations and all that, all the way to when a child visits the OPD. So since service delivery and of course the health workforce go hand in hand, and a bit of infrastructure that I pointed out, we have had to prepare the health workforce or the health workers in all the facilities where we have worked to be able to attend to these children, basically to be able to identify a child with an eye problem. If the health system doesn't allow them to treat them, then they should refer the child to the professional. And that is why now the training in pediatric refraction and low vision has also been very important to improve service delivery for children. Susan, next slide, if there is any. Okay, yes, there is the conclusion. Yes, based on those two points that I've just used to illustrate how we have contributed to the strengthening of the health systems, our observation and conclusion is that we as NGOs, we need to align the government's policies and priorities in order to contribute to the strengthening of the country's health systems. And I say this because we've had the experience. As Brian Golden, when we were looking at which is the best way to provide child eye health services or provide eye health services to children, we had we have believed that the school is the best place to start, and hence the approach of using teachers to screen, which has been welcomed in many countries. However, in South Africa, for a while it was welcomed, and then we were told, no, teachers are not going to be turned into nurses. Teachers, their job is to teach. So we are not going to allow you to screen teachers, rather to train teachers to screen children. So in South Africa, teachers are not allowed to do anything else apart from teaching. And that meant that our approach of using teachers to screen children in South Africa would not work, because it does not align with the government policy and priorities of the role of the teacher. However, as I mentioned earlier, there is the integrated school health program, in which there are school health teams that visit schools and screen the children, and those identified with the problem are referred accordingly. So our alignment and the lesson we've learned in South Africa was, okay, we shall not fight, but we shall support and align with what the government says, hence the approach of strengthening the integrated school health program by training the school health teams. And going beyond training the school health teams, we sent an optometrist to the school to see the children who have been referred or who have been identified as needing refraction, and therefore the optometrist would go and provide the refraction and prescription of glasses, which would then be provided. So that is my conclusion and advice that I would say as a lesson that we have learned while doing this project supported by Seeing is Believing, and specifically with these two elements of the health systems blocks. Susan, I think, is there another slide?
Just thank you, Mary. Just your final slide.
Yes, I think that's the last slide. Vision for everyone, everywhere. Those are some of the children that we've delivered services to through our improved, strengthened system that we have put in place through the Seeing is Believing projects. Thank you, everybody. That is the end of the presentation.
Thank you, Mary. That was a really interesting presentation, and I really appreciated you sharing, as Emmanuel did, some of the sort of constraints and challenges and how you work through those as the project. So thank you very much for that. It was a really interesting presentation. So now this is to everybody. I want to thank Steve and Chiboni they've typed a couple of questions in this sort of section, the chat section of the GoToMeeting, which is in the right hand panel. If anybody has any other questions for either Emmanuel or for Mary, please could you type them into the chat section now, and then we can ask the questions to Mary and Emmanuel. It would be really interesting to hear if you've got any questions or you want them to kind of go into anything in a little bit more detail. While you're doing that, I thought I might just start giving the questions that we've already got. So I'm just going to take one question from each at the moment, but Emmanuel, there was a question to you from Steve, which was sort of around the sustainability of the surgeries. So maybe you could talk a little bit about how your surgeries and the plan for especially for the cataract surgeries, is going to work with the health insurance system. And then maybe Mary, whilst Emmanuel is doing that, maybe the question from Chimboni is around how long did the government take to commence employing the new cadres, the cadres to be kind of taken up by the government? And the questions are just down here. So okay. So Emmanuel, do you want to go first?
Sure. In terms of sustainability for the surgeries, what is in the initial stages of the project, we signed an MOU with the partners, and the agreement is that for the first year of the partnership, facilities or hospitals are given 100% for consumables for cataract surgeries. Year 2, they are given 50%. Year 3, they are given, and year 4, 0%. With the anticipation that Ghana has a health insurance system, so that when hospitals are reimbursed, then they use the monies generated from the health insurance to sustain the activities of the hospital. What is happening practically is that there are challenges because the health insurance is paid in arrears, and the law is supposed to be in 3 months. Unfortunately, because of challenges, sometimes it eats into 6 and 9 months. But the good news is that because of advocacy, not just from operational side, but from various quarters, government itself has set up a committee to review the national health insurance system and introduce what they call capitation, whereby patients will be allowed to select a primary eye care center that they want to visit if they have challenges. They believe that if these things are done properly, then the insurance will be paid on time. The hospitals will have access to the money so that they can use the finances to sustain their activities themselves.
Great, thank you, Emmanuel. And then, Mary, could you answer the question from Chimboni, the one around how long? The question is here in the chat. I'm showing it now. How long did the government take to commence employing the cadre?
Okay, thank you, Susan and Chimbon, for that question. The time varied. You see, this, for instance, the KwaZulu-Natal project, the way South Africa is organized, it's there's the district system. That means that every district is responsible for employing its cadre or its staff. So, in as much as we are advocating at provincial level, the decision has to be made by the district to employ. So you find that some districts are able to make a decision much faster than others. So, but on average, I can tell you that for a 4-year project, the first project that was in KwaZulu-Natal from 2007, it took about 3 years for them to start employing. But I can say also, I think as you would understand and you might have seen elsewhere, once a government knows that there is funding from an NGO, from an external donor, you can tell them how urgent it is for them to employ. But they will not employ until they are so sure that you're actually running out of money and you can't pay those staff that you're paying anymore. Then they finally make a move and start to employ. So it's more or less like that what happened in South Africa in the first project. But eventually they did begin to employ once last year. But even now, it is not like they have employed everywhere. There are still some districts in KwaZulu-Natal which, as Brian Holden, is still supporting and still advocating for them to employ their own optometrists within the hospitals. So it is a very long process, and how long it takes to employ varies from one district, from one hospital to another. So it is definitely, it requires patience, if I should put it that way. You can't start advocating today and they will employ the next month. So 3 years, right now we have a project on in another province. We are again in the 3rd year and they still haven't employed. They're still asking us to continue paying for them, but they're promising they're going to employ. So we are positive that they will employ, but it takes a very long time. It's like now been 3 years. So, yeah.
Great, thank you, Mary. That's a really clear explanation, and yes, I'm sure it is important to have patience, and that advocacy doesn't happen overnight. It really does take a lot of time. And please do, if you have any questions, as I mentioned, please do put them in the chat section, because it'd be great if there's anything that you'd like our presenters to go into in a little bit more detail. And and Sally has a question, Sally Crook. So rather than write it out, I've actually got a question from Isaac. So maybe I might just ask Sally, do you want to just unmute your microphone and then you can just ask your question directly?
Hi, it's Sally here. No, it wasn't a question, it was more a comment, because the BHVI experience in South Africa has been written up for this most recent edition of the Community Eye Health Journal. So I think for some of you who are grappling with this issue of how do you sort of wean governments off from the INGOs having to pay for new services, whether it's the staff salaries like here that Mary's talking about with the optometrists, or what Emmanuel is talking about how do you cover the gaps when the health insurance money does not come through. These are all the same issues. You know, it's basically, it does all boil down to money. And so how do you get the governments to sign up long term to make sure that either the staff are in place or the consumables are being ordered and delivered on time to the district hospitals or whichever level needs the equipment and consumables, and, you know, fuel for the vehicles and things. It's all about, you know, when do you start the discussion with the government about how this is going to be paid for in the long term. And I think some of you will know now that at Seeing is Believing, we really are looking at these sustainability issues more closely and wondering how we can make sure that projects really start from the beginning in thinking about long term, what's going to happen at the end of the 3-year or 4-year project. How will we ensure that the services continue? And again, as Mary sort of emphasised in her talk, if you've spent time training staff, you need to make sure that that training was, you know, good value for money. So again, how are they going to continue offering these eye care services into the future? And it really does require a lot of effort. And I would say my sort of take-home message from the BHVI South Africa projects is you cannot start early enough. And it was a lesson for the bank in KwaZulu-Natal. They had to be very, very patient for the KwaZulu-Natal government to step up to the plate and do what they said they were going to do, which was employ optometrists. And we managed to stick in there and see it delivered in the end. But it was I think, Mary, it was over 5 years before they really did what they said they were going to do at the beginning. But we really didn't sort of waver, and we said, no, this is for the state government to deliver. And in a lot of countries they can do it. It just takes them time to get everything signed up properly. Anyway, probably enough from me now.
Great, thank you, Sally. And I've got another question here to Mary from Isaac. Isaac Buffo, and Mary, he's written it in the chat section, but basically it's saying that you mentioned that the need for integration of primary eye care into the existing primary health system has been necessitated by the absence of eye care service provision. I think this is mainly because existing health ministers focus on health conditions that contribute significantly to mortality. In view of this, even when NGOs step in to support the integration of the eye care into the existing primary health system, a number of health workers show less enthusiasm in accepting the primary eye care integration. Is this true in your case? And if so, how are you able to address it?
Yes, I'll agree with Emmanuel about, and I think we all know the priority given to eye care is not as much as malaria and other health conditions.
Yeah, that's true actually, that's a really good point.
And I think that is why we are all looking at not just BHVI, but I think most NGOs involved in eye care are discussing to avoid, where possible, parallel programs and integrate into the existing health system and broader health issues. So, looking across all the projects that we have implemented, a good example, I think, for this answer would be in East Africa, where we're looking at one integrate eye health into broader health issues, such that when a child goes to the health facility, whether the child has malaria, we would like that child also to have their eyes examined. And we also, with the training of nurses, we want them also to be able, not just because what happens when a child goes to a hospital or even an adult, once the nurse sees, oh, you have a red eye, they don't do anything about it, they refer you straight to the eye unit, which quite often do not have the appropriate medication. So I think our approach of integration is trying to bring eye health, some eye conditions to the fore to be part of the broader general health, so that we do not talk about eyes as if it is not part of the body, as somebody put it. So we believe working at integration, advocating for integration in provision of services, I think will be very helpful, at least as a starting point. And then of course from there, then we may need to look at specialized cases like if it's refractive errors or the surgeries that might be required. But at least for just basic identification, I think it's important that we look at integration to be part of the broader health system, or part of the broader healthcare, primary healthcare, so to speak.
Now it's much better.
Thank you, Mary. Right, because I'm going to give Steve and Chiboni have asked a second question, so I'm going to look at their second questions now, and then in the meantime, if you haven't asked a question yet but you want to, please do write it in the chat section, and then you'll get your chance. So the second question was from Steve. I wanted to ask about the is there long-term, this is for both Mary and Emmanuel, is there long-term support for IT and equipment? And then the second question from Chiboni is this one. Are there establishments in the government Ministry of Health for these personnel? I think it's probably a follow-up one. Are there establishments in the government Ministry of Health for these personnel who are employed by various districts? If so, why should the districts not abide to have them employed? Mary, that's for you again. So that's sort of a sort of follow-on question, Mary, around the employing the cadres, and then to both of you around IT and equipment. So maybe if we sort of start again with Emmanuel and then go on to Mary.
In terms of long-term sustainability for equipment and IT, what is happening is especially for on our part, out of the 35, I think it's just one hospital that is a Christian hospital. All the other ones, and even that one is even supported by government. So the mere fact that it's a government facility, it indicates that when the project steps out, the hospital is going to continue. Most of some of the hospitals, the management has shown tremendous commitment in terms of using their own internal generated power, moving more of the project to add the equipment that the project did not give to the facilities to add up to what we have already given. So as much as we are even around, we can attest that some of the management of the various hospitals are being working to sustain what the project has already built in terms of expanding the eye unit itself, in terms of equipment, in terms of also lobbying government for more staff, because like Mary said, when we also started, there are places that we didn't have optometrists, but the hospitals on their own started lobbying government, because in our case, it's government that placed them. Some now have 2. When we started the project, it was 0. So in terms of long term, there is hope. Just like Sally said, just that initially it's difficult, but if you are able to continue advocating for it in the long run, it will be done. So we believe that when we are on the scene, the hospitals will still continue to run like this, because the understanding in which everybody is catching up with I have part of health, basically the responsibility of government as part of their social contract. Thank you.
Thanks, Emmanuel. Yes, it's interesting how governance sort of comes in across lots of different cross-cutting themes. Okay, Mary, would you be able to answer the question around the establishment of the Government Ministry of Health for the various personnel, and then also the IT and equipment long-term support questions, please?
I'll start with the IT and equipment question, good on Emmanuel's response, because our experience is not very different from Emmanuel's as well. So just in addition to that, I think that is a bit of a challenge for us NGOs implementing this project in partnership with our government facilities. We may provide this during the project time, and may be able to support them during the lifetime of the project. But for us, what we have seen as a challenge is the maintenance of that equipment after the project has ended. Because first of all, when we go to the health facility to do the what shall I call it, to do the analysis of what equipment is required, you will find that it is not that the hospital does not have any equipment at all. They do have, but they are broken. And you'll find sometimes it's not even a big thing that is missing. You're all familiar with this. And then what you have to provide them with new equipment. So maintenance still remains a challenge, I think, for us as NGOs and supporting the government. So it is something that we have to look at very seriously in future if we're going to equip government facilities with equipment. In as much as when you're setting up, providing the equipment, we do talk a lot, discussing about a maintenance plan to be put in place. And they promise, yes, we'll put the plan in place. But what happens while you're still part of supporting the project, when you go to visit and find that a bulb on the slit lamp is not working, you're going to provide it. But 4 years after you've left the project, that same bulb on the slit lamp will have to be working, and the slit lamp that might be the end of the slit lamp. So I think it's still a very real challenge with the equipment maintenance post the project that we really have to discuss and look into the way forward with the partner hospitals that we support. And the other question about employment, yes, they would be part of the government system, but the difference is that excuse me, the districts are not just ignoring to employ, they have committed to employ, but the other factors that come in, it is all how fast do they move to prepare the HR structure to incorporate these people, these new cadre, into their HR structure, to get their budget approved to pay for that new cadre or that new personnel that they have employed. So it's not that they ignore, it is just how quickly they move, the process, they move very slowly. So you'll find some districts may move faster and employ within the first year, some will delay, move very slowly. So it's not that they ignore it. And this we only advocate for employment for cadres that are already recognized in the country, recognized by the province and the district. Therefore, they should be employable. It's just how quickly each entity moves to make that happen.
Oh, there's another question. To me. It's to me. Thank you, Mary, and thank you, Emmanuel, for giving us those responses. Yes, it is interesting, even though the projects are sort of in different locations, how some of these similar kind of issues and challenges that you're sort of facing and how you go about overcoming them. As we started at about 2:10, I'm going to carry on for like a final 5 minutes. So if you do have like a final question, if you could just put it in the chat now, and this is your last chance to sort of put a question to either of our presenters. So any other questions, please do put them in the chat. And then in the meantime, there's a sort of similar question from both Steve and Chimboni Patson, which is around, which although it's for Emmanuel, I think it's probably relevant for both Emmanuel and Mary, which is around motivating staff. So the question from Chimboni is, Emmanuel, how have the outreach staff been motivated to address the barriers you encountered? And Mary, maybe you can also talk about how you've sort of motivated the staff as well. Good. Thank you. And then any other questions, please put them in the chat and then we'll ask them just before we finish.
Can I go?
Yes, so if we do it the same as last time, Emmanuel, if you go first and then Mary second. Thank you.
Yes, in terms of motivations, because it comes in different forms, what we try to do is to support them when it comes to planning their activities, because
statement of question.
Of the capacity to do their general planning, we support them when you go on our monitoring services. Again, when there are equipment that we, as a project, we can use to support the delivery of services, we do that, because in cases where people have been trained to deliver services and do not have the necessary equipment, it becomes a disadvantage to them and it does not motivate them. And recently what happened when we realized the challenge with the health insurance was to review the project itself and seek permission from SiB in terms of supporting the hospitals to be able to run the outreach services, in terms of giving them the fuel, in terms of giving them lunch when they go out there to be able to work. And again, it also boils down to our relationship with them as a project, how we encourage them to continue to deliver the service that they themselves have opted to deliver. So when it comes to motivation, these are some of the things we are doing. And it's also good what SiB itself has come up recently, because when Susan came to Ghana, we all thought of selecting somebody as SiB champion. So when this IAPD and NYDynamic,
he's not my favourite.
We still feel most confident, morale to deliver the service that they are involved. So these are some of the things that as a project we are doing to motivate the personnel to deliver services. Thank you.
Thanks, Emmanuel. Mary, over to you.
That's a tough one, especially when they are not staff that you have employed as an NGO, because as you know, we work through the government's employees who can be very, we don't have control over them. So definitely, as questions being asked, how to motivate them. So basically is to see how we can get them to work to cooperate with us, because at the end of the day, their first they report to the ministry, wherever the employer is. So what we have done is, since we cannot, of course, do monetary reward to motivate them, we have considered some form of recognition of the job that they are doing. So for those staff who have done a very good job, we do recognize their contribution by giving certificates. So we have done this particularly in East Africa with the teachers and some of the health workers. And also, we've realized that just by reporting back to them their achievements, it's also quite motivating, because we realize that if all we expect from them is to give us the numbers, let's say the teachers, the number of children they have screened, or the health workers, want them to report how many children they have treated, they really don't feel like they are part of this, let me call it this project. So we have tried to make them feel like, we know we are working on this together. We all have the same interest, and the interest is the welfare of these children's eye health. So we report back to them what they have achieved. And even before we report back to them what they have achieved, we plan with them. So basically we are involving them in the project activities. So they feel motivated because we are working together. We listen to them during the planning session. They make the plans. They suggest what is doable and what is not doable, and then we agree. And then over the months, as it goes on, maybe once a quarter, when we have the report back session, meetings in the district, we can report back what they have achieved. And we have found that to be quite motivating, not only for the actual health workers who do the work or the teachers who do the screening, but even the management. They get very excited when they hear that, say, this is what our district has achieved, our district has managed to screen this number of children. And they in turn become very supportive of the project and the initiative. So those are the few things that we have learned along the line that we could do to keep the people that we work with motivated and supportive of the initiatives that we're doing.
Great, thank you, Mary. And then the final question we have in, which I think you've sort of alluded to a little bit in your sort of last responses really, which is around, it's from Janet from OEU, which is around how will the NGOs convince the governments to more quickly take on the responsibility of their commitments, and is there any kind of legal means to affect this? So maybe Emmanuel, if we start with Emmanuel again and then go on to Mary, sort of around sort of motivating the government, that would be great.
Yes, in terms of making government take their responsibility, we all know health is a right. But then in terms of dealing with governments, for example, in Ghana, we have what we call, as part of our constitution, the directive principles of state policy. And these are right that government themselves, but when it comes to its responsibility, it's really difficult, because at the end of the day, if the government in power is not doing what it's supposed to do, it just gets down to the people to vote it out when it's time for election. So what, as a project, and what we are doing is more advocacy to encourage government to do what they have promised to deliver to the people, and not to take them on legally. Thank you.
Great, thanks, Emmanuel. Mary? Muted her.
I agree with Emmanuel. It is the government. So for us as NGOs, we really, all we can depend on is the agreements that we have in the MOU, and hope that the government will honor their part of their commitments as stated in the MOU. We do not have any legal recourse against the government. After all, it is the government. We can't take the government to court. So we can just hope that they will honor the agreement they have committed to, and they will honor their word in the discussions that we have, and move on to what we have agreed.
Great, thank you, Mary. And I think for me, one of the things about this this particular topic around embedding the projects within the iHealth systems, and then embedding the iHealth systems into the health systems, means that in theory it sort of helps with that kind of government buy-in, because you're sort of saying, well, it's what you're doing anyway as part of your health systems, but you just sort of add the extra iHealth part as well, and so it's seen as being part and parcel of what anyway they should be delivering to people in terms of, you know, child eye health, adult eye health, etc. So thank you very much, everybody. I think we're going to have to end it there, because we've overran a little bit, but I think it was worth it to kind of get these final few questions. Additionally, people have made some various comments in the chat sections as well, just to give their little input in terms of what they found in terms of embedding iHealth systems, or, you know, any comments on any of the responses given. So do have a look at those. Once again, I want to especially thank Emmanuel and Mary for doing excellent presentations, and for giving such interesting and informative responses to the questions. Also want to really thank those people that gave the questions as well. I think it's been really useful to kind of get from you which bits you were sort of most interested in, and it's given sort of me a real overview of how the projects are working, and hopefully it's been the same for everyone. Thank you again for Emmanuel and Mary and everybody. Thank you so much. Bye.